Welcome to this expert interview for pilotforpulmonary.org. I'm Dr. Gary Ferguson, Director of the Pulmonary Research Institute of Southeast Michigan and Clinical Professor of Medicine at Michigan State University. Today I have with me Dr. Nick Hanania. Could you introduce yourself, Nick?
Of course. I'm Nick Hanania. I'm an Associate Professor of Medicine and Director of Airways Clinical Research Center at Baylor College of Medicine. I'm a pulmonologist. My expertise is in asthma and COPD.
Great.
Thank you for having me.
Actually, delighted to have you here. You know, there's a lot of new stuff going on in COPD, especially with the new 2017 guidelines. And one of the interesting things and important things I think inside of there is the whole issue of addressing not just the medicines we're using, but how you use them, how we deliver them. So tell me a little bit about it. Is that really important?
Absolutely. I mean, as pulmonologists, we sort of focus on medications usually, and I'll tell you more about this in a few minutes. But for the first time, GOLD 2017 addresses the need, which is a very important need for us as pulmonologists, but also as clinicians, whether in primary care or other, to assess inhaler device use in patients with COPD, because that's something that we sometimes forget, and it's so important that it affects outcomes.
So how do you do that? I mean, if you're busy in a clinical practice, how do you do that?
Well, I mean, we assume our patients, when we prescribe medications for COPD, and as you know, most of them are delivered through the inhaled delivery route, and we have at least 4 platforms out there, including the metered-dose inhaler, the dry powder inhaler, the soft mist inhaler, and of course the nebulization. Whenever we prescribe medication, we assume the patient is going to, first of all, fill his or her prescription. That's an assumption. Another assumption is that they're going to do it right. So unless we see them and we teach them how to use their inhaler, we cannot assume that. Each inhaler, no matter how easy is it to use, need to be taught, because many patients commit errors. There are several studies now, including ours, that shows up to 60 to 70% of patients misuse or have at least some incorrect steps in using the inhaler device.
Wow, so now you not only have to prescribe it, they have to buy it, they have to take it, and they have to take it correctly? That's really demanding.
I would say take it correctly first, because if they buy it and they spend money on it and don't use it right, we're not going to get anywhere. And it's a waste of their money and waste of our time and their time.
So how do you figure that out? What happens, so you've done all those right things on the front end.
Sure, ideally, and that's what the GOLD 2015 recommends, is that you assess inhaler use in the office every time the patient comes. Practically, what I do is I ask my patients to bring their inhalers to the office. I see what they're taking first, and if I don't have placebo inhalers, I like them to at least demonstrate to me how they're using it. Ideally on a placebo device, to see and then coach them how to use it. And this is not a one-time deal, Gary. As you know, we all tend to forget, and so assessment of inhaler device should be on a routine basis when these patients come in.
So are there certain things that give you a clue as to which delivery system might be better for certain patients, or how you just kind of take a guess?
Well, actually, you know, there are some clues. So, you know, some patients, like I see elderly patients who have physical disability or have some cognitive dysfunction, may not master a device, which is like a metered-dose inhaler, which is a great device because it does involve physical function, and they have to know how to perform the 9 steps that it requires. So when I choose a device and a medication, I have to know what the patient is going to use. Of course, other things play a role in the choice of inhaler device, including, obviously, patient's preference. We're in the era of shared decision-making, so we really have to discuss this with the patient and a caregiver if it's an elderly person that we're dealing with.
So I know you've done a lot of work in this area, Nick. So are there gaps? Are we missing things? What do we know about this problem?
Well, it's fascinating. I mean, we knew that patients do not know how to use inhalers, but charity begins at home. And we actually just performed a large survey on healthcare professionals in the United States. We presented these data at the American Thoracic Society meeting. We surveyed clinicians, not only pulmonologists, but pulmonologists, primary care physicians, and non-physician providers on what are their perspective on using device inhaled delivery system in the United States. And Our results are shocking. 55% of pulmonologists and many more in primary care don't check their inhaler device on newly diagnosed patients with COPD. Most of them put the drug first before considering the delivery system. We also surveyed patients, and actually patients themselves need education because they also put the drug first. They are not aware of the need to master an inhaled delivery system when they are prescribed medications. And so both groups need some education in this field so that we can achieve better outcomes.
And then obviously, as you mentioned, if they aren't doing well, it may not be because they need more medicine. They may need to get the medicine correctly to double check on that.
Correct. And not only that, but there are studies now showing that if they don't take it correctly and if they're not adherent to the medication, whether because of comorbidity or because they forget or they cannot use it right, it's been shown that it is associated with worse outcomes, including exacerbations of the disease and hospital admission. So it's not without a consequence.
Right. We worry a lot about adherence, and yet we don't think about these so often. You also mentioned a few things: cognitive impairment, arthritis. Those things certainly matter. Does these comorbidities really play into this?
Yes, and this is another thing. As pulmonologists, we focus on the lung, but COPD really affects multiple systems in the body. And we have to look at comorbidities. That's something that the Goal 2017 emphasized on, not only when it comes to inhaled delivery system, but when we manage these patients. Some comorbidities, like the ones you mentioned, may affect how they use their device, especially memory loss is another one, cognitive dysfunction, physical dysfunction may play a role in how they use their device.
Yeah, even visual impairment. We assume that they can see everything and all that kind of stuff.
That's right. That's right.
Well, Nick, thanks for joining me. It's been a great discussion. I appreciate all your insight.
Thanks for having me.